Hello, everybody. Good evening and welcome to BioMonde Live. Thank you very much for joining us this evening. It's wonderful to have your company. My name's Rebecca and I'm the Clinical Support Manager here at BioMonde. And joining me this evening is the brilliant Jill Sykes. But before I introduce Jill properly to you all, could somebody just let me know, please, if you can see and hear me clearly in the chat? If you can just pop a yes in there, that would be great. Fab, brilliant. Oh, thank you. You're all stars. Right, so let's dive in. So tonight's webinar is managing complexities with heel ulcers. And as I've already said, we're joined by the brilliant Jill Sykes, who is advanced podiatrist at Harrogate District NHS Foundation Trust. So the webinar this evening is expected to last around an hour, but we will be setting aside 10 minutes or so at the end just for any questions that you may have for us. And do let us know you're here and that you're enjoying the webinar. Feel free to say hello in the chat. And also, if you've got any questions for either Jill or myself or my colleague Vicky, do feel free to pop those in the Q&A section of Zoom. Both the chat and the Q&A buttons can be found just by hovering at the bottom of your screens. So hopefully you'll all be able to find those okay. So here's the lovely Jill who's going to be presenting for you this evening. And let's have a little look at what you can expect from the webinar tonight. So Jill's going to be presenting for you, and she's going to be discussing how to assess complex heel ulcers, as well as exploring holistic treatment pathways. We're also going to be looking at some debridement options for heel ulcers for you, as well as how to manage complex wound types, and then some case studies for you as well. So that's enough from me for now. I will pass you over to Jill, who's going to be presenting. Jill, if you'd like to share your screen, I will just stop sharing mine and hopefully Zoom will be nice and let you share your screen. There we go.
Lovely.
Perfect. If you just want to press begin on your slide, it should load up nicely then. There we are. Perfect. Jill, over to you. Thank you, everybody.
Hi, everybody. Good evening, and thank you to Rebecca and BioMonde for introducing and asking me to present this evening. So a little bit of background about myself before we kick off with the whole presentation. So I'm an advanced podiatrist working over in Harrogate District NHS Foundation Trust. My special interest is tissue viability, and I'm also a trustee of the Society of Tissue Viability, which I have been a trustee now for over 10 years. And the last couple of years, I've been invited to be a member of the Legs Matter Coalition group, which pulls together a whole variety of disciplines managing the lower limb and the leg, including the foot. That's been really important to me, and it's given me lots of networking and lots of advice and professional support, especially over the years with the Tissue Viability Society. In the 34 years that I've had NHS experience, I've worked across all different healthcare settings and currently do so as we speak. So I work in primary, secondary and tertiary care. So my overall passion is for the holistic approach to the management of complex foot wounds. As Rebecca's mentioned, my presenting objectives today will look at offloading of the heel, primarily the heel. I will cover a couple of little other areas, but mainly the heel. To look at the management of that heel holistically, and to look at how the assessment is crucial in the complex of managing these heels. I'll show you a couple of case studies of the complex management and look at how I manage them as a podiatrist, and also how I worked in the multidisciplinary arena to get the best care for that patient. I'll then look at some offloading devices that are available for me to use in my clinical practice, and then look at how I manage a heel wound and its debridement of that wound. So look at what happens if a heel goes wrong. Apart from maybe a calcanectomy, the end result is generally a below or above knee amputation, which is massive to patients. And as you see from this photograph, This has been going on for years. We all have heels. Hopefully, everybody listening to me today has got 2 heels. They're crucial in the gait cycle, in our balance, in our walking, in our running, our activities of daily living, and keeping us independent every day. The heel is the biggest bone in the structure of the foot, of which each foot makes up 26 bones. So below our ankles today, we have 52 bones below our ankles. The NICE guidelines help us in assessing and developing the development of a foot ulcer. So they tell us that when we're examining the feet of a person with diabetes, we must remove their socks. Now, I'll hang on to that for a little while. And even as podiatrists, sometimes it has been known we don't remove both socks and shoes. That's crucial in the management of looking at a diabetic foot. We must remove all bandaging, both feet and legs, and we must examine the feet for evidence of risk factors. So looking at if a patient has neuropathy, using a 10-gram monofilament as part of the foot sensory examination. Looking at limb ischemia, there's different guidelines on peripheral arterial disease, looking at pulses, looking at hair loss, looking at symptoms and signs of critical limb ischemia. Any tissue loss, breakdown and ulceration. Any formation of excess callus, which may later on break down and ulcerate. Any infection or inflammation, foot deformity, which can go on and lead to callus, breakdown, tissue loss and ulceration, and ultimately gangrene. This is the thing we want to avoid, and Charcot arthropathy. That can all occur in a diabetic foot. So the EPUAP defined a pressure ulcer as something that's an area of localized damage to the skin caused by prolonged or excessive soft tissue pressure along with shear or friction, or a combination of both. The EPUAP developed these guidelines and they looked at categorizing different areas on the heel, particularly for the podiatrist, but looking at whether things are category 1 through to 4. So category 1 is a non-blanching erythema, a redness on intact skin. Please be really careful if you notice this. This can quite quickly move on to a category 2, 3 or 4. So full thickness or extensive destruction and tissue necrosis. These guidelines are available on the website. Very useful to print off, laminate and have in your clinic rooms at hand. Pressure sores with the NICE guidelines, developed in April 2014, said that we should carry out and document an assessment of pressure ulcer risks for adults, either being admitted to secondary care or care homes within the NHS care. It's all our responsibility, such as in primary care and community care, to look if a patient has had any of these risk factors below. So any significant limited mobility, for example, a patient with spinal cord injury or a stroke, for instance. Have they got loss of sensations I've managed before? It's not just diabetes. Have they had a previous or current pressure ulcer? What's their nutritional status like? Do we ever look at their nutritional status? Their inability to reposition themselves and any cognitive impairment that's significant. So is it diabetes, is it pressure, or is it both? Both diabetic and pressure ulcers are sores that if left untreated can lead to bacteremia, sepsis and death. Diabetic ulcers can occur on any part of the body, whereas pressure ulcers occur on the parts of the body where there are bony prominences. So in reality, if you have a diabetic with a pressure ulcer, we have to take great care in prevention and management of those. There's a fantastic document for you all to go away and look at that's just came out last year. It's developed by Diabetes UK, and it's a consensus document redefining and demystifying offloading. It states in there that foot ulceration among people with diabetes urgently needs to be addressed to limit the associated social and economical costs as well as the personal cost to the patient. To me, that last part of that sentence is crucial. It's all around the personal loss to the patient. The principles of diabetic foot ulcer management include wound debridement, which we're going to talk about a little bit in a while, offloading, revascularization, and the presence of infection and therefore antibiotic therapy. So the risk factors we look at for pressure ulcers: have we got direct pressure on that foot? Is there any shear, any friction, any previous damage? We talked about looking at the vascular status. Are we sure that we know we're confident at palpating pulses? And even these days, looking at toe pressure indexes. Any sensory impairment? Is the patient neuropathic? Can they actually feel what we're doing at all to them? Or are they going around and injuring their feet? Any acute illness that might affect the foot pathology? Levels of consciousness, can they move themselves independently or not? Any reduced mobility? Their advanced age, our caseloads are growing and growing in time as the average age of our patient increases and increases. Now, the malnourished we've mentioned before, dehydration, really important. Is the patient actually getting enough fluids in their body? And moisture. So the heel is probably around 70% of my caseload these days in primary and secondary care. It's been defined as the second most common site for pressure ulcer development, accounting for up to 28% of all reported ulcers. And indeed, Clark et al. Concurred, identifying in their survey that 261 patients experienced their most severe ulcers in the heel. So when we look at these pictures here today, we can see areas that are intact, that might be blanching, non-blanching, may have started the top row in the middle may have started life as a fissure, as a split in the heel due to the dryness of the skin. Do we advise emollient daily for these patients? It's all around prevention. Some areas may be not categorised, they may be unstageable on deep tissue injury, top right, and we may get extensive involvement of the Achilles tendon, which goes right up to the back of the foot. And that adds to a real complex offloading problem for us. And then the bottom right is a gangrenous necrotic heel. That spells trouble. So when we're looking at wounds, we look at our 3 debriding aims. In my head, when I'm seeing a patient, I have limited time to see him, as we all do. And in my head, I'm thinking of 3 debriding aims. Preventing resloughing if possible. That's not always possible if the patient's general health is bad or their comorbidities are poor. But prevention of death of debriding agents, such as the larvae therapy. Are we offloading that area enough so that the larvae therapy have enough time to do their work, fill themselves up, kill themselves, and be removed from the wound bed? That needs careful offloading, which I'm going to talk about in a little while. And ultimately promote healing if we can. So it's not just heels, the foot is covered in bony prominences. Unfortunately, we look down at our feet now and everything is prominent, from our toes, our little toe, our big toe. Even if we don't have deformity, we have bony prominences. The end of the 5th metatarsal, for instance, is what we in podiatry term as a styloid process. That is a bony prominence and quite prone to breakdown. So if we look at the top left-hand picture, this shows us the 5th metatarsal head. That's a bony prominence which will always be there. That's very, very vulnerable, as is the 1st metatarsal head. The area down on the top right is the styloid process I talked about on the lateral border of the foot. This area under here on the bottom left is underneath the 5th metatarsal head. And just a little bit lower down here on the bottom right is a necrotic gangrenous area. These 2 bottom pictures probably prone to bone. They will be osteomyelitic and will maybe end up in having to have major surgery if not debrided and managed with pressure relief and debriding agents. Bed ends. So we're looking at air mattress pumps, and the sanitizer hand gels that we're all paranoid about using these days. They're all at the end of hospital beds. Let's be careful that where is the patient placed? Is the patient slipping down the bed? If you have a tall patient with long legs, are they resting against these devices permanently? And these are the sort of pictures that we see with permanent pressure damage. So just look at your patients and where they're positioned. We call it the heel SOS, strictly off surface. That's the thing to remember in your mind. Is the heel actually touching any surface? Can we elevate that heel? Can we use special bed mattresses? Can we use pillows? Careful if you're using pillows to offload heels. Unfortunately, we know every pillow, as we know at home, is different quality. And given time, a pillow will flatten. Its quality will diminish, and the patient's weight of their legs, whether it be one leg or two legs, will actually end up flattening the pillow, and the heel will end up being onto the mattress. Just be careful that that doesn't happen. If you're floating the heels on a chair or a buffet, if you're in the community setting and the patient is elevating their legs, whether they've got recliner chairs, try and prop something, a pillow or a cushion underneath the calf muscle so that that doesn't end up having pressure itself. And finally, the bottom right is what a soft cast. I'm going to talk about soft casting in a moment, but that's a device as podiatrists we've found very successful in relieving pressure for patients' heels. So soft casts for podiatrists is something we can make chairside. We can make in the patient's home, at the side of the bed on the ward, in the clinic setting. They're made quickly and easily by trained podiatrists that are competent in using the tool. They're quite fiddly to do. You've got to act quite quickly once you've opened the pack of soft cast. So the key is being prepared and getting everything ready. But they're used to prevent or treat heel ulcers. So if we've had a heel that has been ulcerated and is prone to pressure, the patient can continue wearing that as a prevention. It helps improve healing times and the reduction in pain. I have had patients where I've soft casted their heels and immediately, as they put the foot down, they've been pain-free. They help to reduce the shearing and stretching pressures and forces that go over that heel. They're lightweight, they're thin, they're only one cast thin, so they can be popped into patients' shoes or dressing shoes, Darko shoes, trauma shoes, and the patient can then sit out and immobilise. And for a lot of these patients, it's really important that we keep their mobility going for other health reasons. The big but is that we have to monitor for cast rubs. Make sure these casts are inspected regularly, daily if possible, by relatives, carers or nursing staff to make sure that this doesn't happen. So make sure that the cast is never placed directly onto the skin. If you always have to have something between the cast and the skin, whether it be a soft band, cotton wool bandaging, or just plain blue line or yellow line Tubifast. The cast can be sandwiched between two layers of Tubifast, and that's quite adequate to stop that friction and causing that picture below. If we get this, complete definite removal and contact the podiatry department immediately. So heels are designed for weight bearing. When we think about our gait cycle, when we think about how we're walking, how we're putting pressure through the heel, at any point in time, our whole body weight goes through one heel while the other heel is swinging its leg forward to take the next step forward. So be really conscious of the amount of weight that's going through this small bone. It is the largest bone, but it's still a small bone. It's got a thickened area where the dermis is thickened, and it acts as an absorption system, protecting the heel from pressure as much as it possibly can. But we must realise that with the ageing process, things do diminish and get less and less. So damage can go unnoticed in patients with neuropathy for days or weeks at a time. The patient may present in our podiatry clinic saying that they've noticed a blister, or they just thought something was weeping, or they noticed redness on their sock where it was bleeding. So in a given time, something from the picture on the far left can turn to the middle and then post-debridement end of life on the right. So the sooner you refer those patients into podiatry, the better. Always be a bit of a detective. Always ask the patient the questions. If you can, if they're mented to do that, if they're able to talk, or ask relatives or carers about the patient's position, their sleeping position. Particularly the community patients who live alone, who don't really go out much, the only people they see are the healthcare professionals. It's really important that you ask about how much time they spend in a certain sleeping position. If they move in bed or not, it might be that they've had hip replacement, for instance, so they're not able to sleep on one side or the other, and they permanently sleep on the back. Once you hear those sort of comments, alarm bells start to ring. So it's about getting those patients offloaded, and things like repose wedges will help. They're instead of pillows, they don't deflate, or they can be reinflated if the pressure causes them to go down, so they're completely zero pressured all the way through their sleep. And if they do need turning, it's going on to 2-4 hourly turns as appropriate. So quite quickly that bottom picture can occur. So the guidelines recommend, the NICE guidelines in 2015, that people in hospital who are at moderate or high risk of developing a diabetic foot problem should be given a pressure redistributing device to offload the heel. So whether that be specialised mattress, repose wedge, offloading devices from the podiatrist, that's what NICE recommend. So I'm going to talk to you now about some offloading devices that I've used over the years. I've worked in 2 trusts over my 30 odd years of being a podiatrist, and it does vary. The availability does vary. So check your local availability. And if you feel that there's maybe more a patient could offer, speak to your podiatrist, speak to your chain supplier. Now supplies are bad at the moment. It's difficult all over the place to get things, but do speak to people about what more could be offered for that patient to be offloaded. So get hold of your podiatrist and also your orthotist. The orthotists are an invaluable profession, very tiny, smaller profession than podiatry, but pick the phone up, find out where they work. There will be one in your trust somewhere, usually based in the hospital, but talk to them. They're experts at looking at devices, tweaking, altering, looking at footwear. So orthotist and podiatry, let's join together, let's work together. Most of my time is spent coordinating and organising multidisciplinary joint appointments, whether it be online, like we're doing now, or whether it be face-to-face, which I'm getting used to going back to a little bit more at the moment, and bringing the patient along, allowing that patient to be part of their care, getting them on board so that they're more likely to be involved in their management. And let's realise the general principles of each offloading device. Each one I'm going to explain to you in a moment has got a specific and different function. And not to say we must complete a thorough assessment of that patient, the individual patient, their mobility, their vascular status, etc., which I have spoken about previously. So this is something I use on patients. It's called a podesbu. It's designed for patients for plantar flexion contracture, for heel and toe ulcers and hip rotation. So I use it up for heel and toe ulcers, mainly heel, and it completely will suspend. I'm going to try and the area right at the back of the heel, you can put your hand right through the back of that device. The heel is completely suspended in midair. So when the patient is sat, whether it be in a chair or even at bedside, the heel will have no pressure on it whatsoever. The patients can also wear them in bed. So if they're laid flat in bed, they will be completely suspended in bed. There's no pressure in bed, but generally for the patients who are really immobile. And did you know on the side of, at the back of the podesbu, there is a small rotation rod that you can place laterally or medially. So you're getting a patient with lateral and posterior heel pressure because they've got lateral rotation at the hip. You can present this rod and rotate it to that lateral side to keep the patient to a central position in bed, and that stops that lateral pressure. I have a young type 1 diabetic, she's 45 years old. She had a severe fall, fractured pelvis, and was lucky to survive. And she is very poorly controlled diabetic, and she has lateral hip rotation and presented to me with bilateral lateral posterior heel necrosis, by this time gangrenous, and lateral tibia osteomyelitis. So put her into 2 PODUS boots. She hated them. She hated them to start with, but got used to them, wears them in bed all the time, and actually were nearly intact, which saved both legs and both heels. So they're very useful and they do have a place. Other offloading devices, again, you've got to consider mobility. Top right, we've got the heel wedge shoe. The heel wedge shoe is ideal for patients who are fairly mobile, will mobilise around the home. They will generally need a walking aid to help assist with this device because the foot will be altered in its position. And also the body weight will be taken off the heel. So when the patient is walking, they will be walked through their mid and forefoot. So the heel will not be allowed to touch the floor. So the patient will be walking quite differently. As podiatrists, we have to watch these patients, attach these devices and watch these patients walk, give them a little bit of assistance, teach them how to walk differently to prevent the risk of falls. If we feel a patient might be at risk of falls, we might fit something like, it's the picture on the left-hand side, which is a peg assist insole. Now, this one can be fitted into a flat, darker or trauma shoe, but what we do is take out the pegs out of the area, which is generally the plantar aspect of the heel, to offload that heel completely. It's not very good in patients who are a little bit overweight because the pegs will flatten. However, that does have a place and we've had good results with that. The Heel Pro boot, bottom right, this one is very good for patients who are very immobile, generally nursing home or ward patients who don't move around much in bed, and these are very comfortable to wear. We get, as you can see, they're like a cushion that we wrap around the patient's foot with 2 big wide Velcro straps, and so we get very little pressure or rubbing from device for that one, and they're good. Again, the heel has got a window at the back and they're completely offloaded. Again, that's a good one if you've got malleolar ulcerations as well. So we go on to the more rigid devices for patients who are more mobile, the ones that come walking into clinic who tell us that they rest their feet, but actually we're not sure that they really do. But these devices here, both short length and full length, will completely offload the foot and the leg. So they will take the whole body weight through a rocker-soled device, which it gives maximum offloading of the foot, and it will also eliminate all the pressure points. It's something, it's air cell lined, so you pump the devices up at the side with valves to completely immobilize the leg into the device so that the tibia is not moving around, and we can graduate compression to help reduce the edema as well. So the total contact air cast walker boot is really good. However, it is removable, and it's only as good as the patient that you fit it to, and they have to promise that they don't remove it, only for bed, only for bed. Other things that we use that are gold standard for podiatrists in completely offloading the foot, the total contact casting, different systems available, again building relationships and negotiations with the orthoplasty technicians, and making sure that we can work multidisciplinary with them so that we're available to them when these casts are removed on a regular basis, to be able to allow us to reassess the wounds that are underneath. So very good for plantar surface wounds, Charcot foot, and blistering on the rocker bottom sole of the Charcot foot. The right hand picture goes that little step further, literally, pardon the pun, and this is a bowler walker. So the patient's placed into a total contact cast and then put into a bowler walker, and if you can see from the picture, there is complete fresh air from between the cast and the walker, which is bound to the total contact cast to stop the movement of the foot and the leg while they're walking. That can cause, or probably will cause, a leg length discrepancy. So we have to sometimes assess that patient if they've got really poor mobility, that we could maybe add a raise to the other shoe or the other foot to balance them up, particularly if they've got pelvic or back problems. So contraindications when we are offloading and considerations, we've got to think about the wound management, any infection or dressings underneath, and we talked about larvae therapy especially because they're so effective. We've got to keep these little things alive. So it, you know, on a heel, it's really important that you consider those previous offloading devices or work with your podiatrist to get that ultimate result. Any lymphedema or edema that's there, that contraindicates any sort of total contact casting. And look at the concordance and the social care. A lot of the patients that we see in our clinics, diabetic clinics, generally struggle with their diabetic control and their social life really. And we still have to take a holistic approach, looking at the gait, the balance, which you've mentioned before, any DVTs, and look at where the wound is actually placed. Social considerations that we in our heads are thinking as we're going along assessing these patients. What's their occupation? Are they able to actually work if we put them into any offloaded devices which doesn't allow them to drive, for instance? They're the sole breadwinner, they don't get paid if they don't work. It's their independence. What are their activities? Their intimacy, their sleeping pattern. Is there a malodor to the wound? Is it itchy? Can they bath or shower? And the worry from a lot of these diabetic patients of what the outcome is. They always come in with a story that their auntie or their grandma or some relative has had to have their legs removed because of gangrene, because they're diabetic. It's about getting to know your patient. So finally, really get to know your patient, get their trust and their respect and work in partnership together, and you're probably a lot of the way there. So I'm going to talk to you about a couple of case studies now, and the first one is a type 1 diabetic male, 70 years old, and unfortunately in 2017 had to have a left above knee amputation. So his HbA1c was between 76 and 90, and when we're seeing these sort of patients in our multidisciplinary diabetic foot clinic, we always do our studying before we see the patient to look at what their previous HbA1c has been, and usually that's quite an alarm bell when we see 76 to 90, and that's over quite a long period of time. So we can now look on our electronic systems at over a few years' time to see what their general control has been. So consequently, he's neuropathic and was referred by the district nurse urgently for a deep tissue injury of the right heel. So no known etiology. As podiatrists, we see these patients, especially if they're neuropathic. First question, what caused it? We need to know, if we can do, what the etiology is. And a lot of the time, the patients are not sure. Like I mentioned before, they notice blood, fluid, a wet sock, so they're not sure how it's been caused. Big thing was he was a businessman, very independent, lived alone, and mobilised using a wheelchair. So he propels around his house, which is a house with stairs that he never goes up into because he's above knee amputation. He's got a prosthesis, but he doesn't do stairs. But he propelled himself around the home with the remaining heel. And that happens a lot. He's a big guy as well, tall, stocky chap. And so a lot of pressure, as I talked about before, goes through any heel at any time. We've got to think about him pushing along the carpet or whatever floor surface in his heavy wheelchair with that one heel. So this is how we present it to podiatry. A lot of debridement done sharply around the periphery there. It was a category 4, not stageable at that point because we couldn't determine what was underneath that necrosis that was occurring. So there's lots of things to consider here. Straight into our MDT foot clinic, where we look at diabetic control with diabetologist and diabetic specialist nurse, and also the vascular status. What's his vascular status like? And we're fortunate enough to have vascular surgery and vascular specialist nurse in the clinic as well. So 4 weeks later, we look at the left-hand picture where we've got calcaneal exposure, osteomyelitis, is on long-term antibiotics, admitted for IV antibiotics and necrosis. And afterwards, post-debridement with larvae therapy on that right-hand side. Now, I did actually need a second application of larvae for that, but you can see that necrosis was completely lifted, apart from the two little areas around the periphery there, which were sharp debrided off. They were lifted nicely, and this was allowed then to start to re-epithelialize with a second application of larvae. So the treatment plan was immediate referral, as I say. We put him into that MDT clinic. It's really important he got his diabetes under control as well. The X-ray referral determined what we thought. There was osteomyelitic changes going on in the calcaneum. So he was immediately put on to intravenous 1 gram flucloxacillin, and we debrided with the larvae therapy. The offloading, we used chair and bed. So I used the PODUS boot, the fluffy one where I can put the hand through the back when he was in bed, and in chair as well. It took quite a bit of getting used to that. But again, once he knew what the actual ultimate aim was and what our goal was together, he was well on board. When he was discharged from hospital, we liaised very carefully with the diabetic, the district nursing team. And so it meant that I would go in 1 day a week, the district nurses the other 2 times a week to do the wound management. And it was a full explanation to this patient. He already knew through his diabetes that he'd lost his left leg, and he was quite aware and needed reassuring that hopefully we were going to salvage that right. So the outcome was that his poor diabetes control continued. He lived alone, he struggled to cook for himself, so we got social services involved. It was his poor diet really was the underlying long-term problem. He'd been left to his own devices, and his non-compliance initially in not wearing his offloading devices like we'd asked him to. So he ended up, we didn't get him healed. He did end up with a calcanectomy, and sometimes you've got to realise that we don't get the best outcome for all of these patients, and that's the thing that hits hard sometimes as a clinician. And still his remaining leg he still has, but that does remain in the balance. So case study 2, again, another male. I hope you're getting the theme to this. Type 1 diabetic, insulin dependent, 54 years old here, a little bit younger, morbidly obese, and his HbA1c was 103. So that was extremely high and was persistently in the late 90s and 100s. He lived at home with his poorly mum. She took priority. This is the background history. And then he separated from his partner. So things psychologically were going on for him. There were other things in his world than him wearing his footwear and rubbing a blister. He noticed the wet sock that I talked about earlier on. So on admission, this is the first metatarsophalangeal joint. So this is around the medial border. And he was presented on the ward. He wasn't referred to podiatry for 3 weeks. Now, if you don't take away anything else from this presentation, I really would like you to think about rapid referral to our teams where possible. He ended up again on intravenous antibiotics and bed stay. He was debrided biologically with the larvae therapy and told to rest as much as possible with offloading, and so it's more for offloading than heal. We discharged him on the outpatient antibiotic therapy pathway, which meant close links with that nursing team who were very specialised in looking at giving him intravenous antibiotics at home. He needed to be at home with his poorly mum, on the proviso that he tried to rest his foot. And we looked again at shared care with the district nurses. I'm on a hotline, speed dial to all my nursing teams that are invaluable to me: tissue viability nurses, practice nurses and district nurses. His compliance again was an issue, and it's something that we're trying to get over, this psychological aspect to diabetic foot ulceration as well. And then long-term orthopedic footwear. This man was very edematous, and there was no way he was ever going to go back into retail footwear off the shelf. So the larvae therapy, it's a biotherapy involved. It's a disinfected maggot, so it's a fly larvae, and it's excellent on on necrotic wounds and slough, and I'm sure you've read all around the larvae therapy. For us, they are brilliant now. They're in the bio bag. In days gone by, I used to put them on free range, which is always good fun when we're chasing them around the patient's bedside with the escapees. So buying them into the bag is brilliant, and they start off like little grains of rice and end up really fat, and hopefully eat so much and digest so much that they kill the cells, and we can remove them as clinical waste and dispose of them. They're excellent, I think underused as a first debriding agent, and I think as a podiatrist, if we can get over the yuck factor with actual application of larvae, they should be seen as a first line debriding agent in my experience, especially for me in podiatry. If we have like the stringy slough, the stuff that will not lift through sharp debridement, that will take weeks, applying a medicated product, that these will do the job in one application normally, or two maximum. So the outcome for this guy, he's ended up, as you can see, post larvae therapy. We have a little bit of bone exposed, which went on to be, it was excised off using clippers by chairside. Just don't forget he's neuropathic, so he really doesn't feel a lot, which is to us is an advantage when we're debriding these wounds right back. And he needed, like I say, one more close bag. This man has gone on to completely heal and is independent. As I said, complete wound. He had the shock of his life. So much so that now he's got a complete new lifestyle, completely new changes. He's got over losing his mom, who passed away. He's now a single man, but he lost weight. He still has 2 remaining feet and legs. Winner, winner. And that's all that we go on to, we want to do. That's our ultimate aim when we're dealing with diabetic foot. In whatever profession we are, we need to share our knowledge. So frequent podiatry appointments. He now keeps these appointments. It doesn't DNA. We're not chasing him all the time. Where are you? You've not been to your appointments. And he has the SOS podiatry contact card. So at any time, he can give us a ring, and we will see him as an extra, or whenever he wants to be seen. Oh, my computer's frozen. There we go. So let's think, we're in a no blame environment here. What we don't want to do is beat each other up about, you know, well, you didn't refer that in, what are we going to do? This is a Datix. We need to do a Datix reporting, because I think that by Datix reporting, it's not beating people up, it's about us sharing our experiences and learning, not just from good experiences, but from bad ones as well. So let's get involved in local pressure ulcer meetings, investigating our incidents, themes, and looking at solutions. I try and meet with my colleagues on a regular basis. We thrash out what went wrong, what went right, and where we can learn. So we look at working multidisciplinary to resolve these issues. And like I said before, we don't all know everything. And my nursing colleagues offer me over the years so much support. So it's practice nurses, ward nurses, district nurses, TVNs, podiatry, orthotists, the list goes on, vascular surgeons. The patient, the carer and the relative are at the centre of all of this, and it leads to better outcomes. Another message, there's only 2 I want you to take away really today, but the other message is a compact mirror. I absolutely go on and on about this. Let's pop one in our pockets. All of us in healthcare should have one in our uniform pockets. They're not bulky, they don't take up any room, and we can stick them under the tap, we can wash them down, but they're so good for checking heels. So they can be slid under when your patient can only be lifted 2 or 3 inches off the floor because of mobility issues or lighting issues. Get your mobile torch going off your phone, stick the mirror underneath and inspect these heels. All those pictures that I've shown you before of deep tissue injury, of category 4s, are all preventable. And they're preventable by us as healthcare professionals inspecting those heels, not missing those heels and offloading that pressure. So in summary, a diabetic ulcer is a sore that develops on the foot of a person with diabetes. A pressure ulcer is a sore that develops where bony projections are pushed against firm surfaces and occurs in bedridden or immobile patients. So, offload, offload, offload. And I'd like to thank you for all your time and attention, and you can go out and buy your compact mirrors as soon as you like. Thank you very much.
Oh, that was an absolutely brilliant presentation, Jill. I loved every second of that. And I hope everybody did at home as well. So let's move on then to the questions. And I will just share my screen, 2 seconds. Okay, so hopefully you can all see the BioMonde logo on the screen now. But let's have a look, Jill, at what questions that we've had through for you. So the first one we've got from Inez says, what is your experience in terms of a trained tissue viability nurse providing debridement prior to podiatry assessment, as waiting for this assessment can often delay care?
I think as podiatrists, you know, debridement is something that nurses are encouraged to do, that are competently trained, and that's fine. However, regarding the foot, I think it's really important that you know your skeleton, you know the tissues that are really at the surface of here. There's tendons, ligaments, muscles, anything can be severed, and I would hate, particularly towards the forefoot, there are a lot more complex areas that you should really leave to a specialist podiatrist to debride. I think that the heel, we've got the plantar fascia and the plantar muscle running out from the attachment of the heel on the sole of the foot, and then the Achilles tendon. Please do not go anywhere near an Achilles tendon, because if you sever an Achilles tendon, it's not recoverable and the patient will have foot drop for the rest of their lives. So I would be really cautious. I'm quite happy when I'm in podiatry, and maybe it's worth making connections with your local podiatrists to do video calling if they're not able to physically get to a patient, to take photographs of the patient's heel or foot ulcer and send that along, you know, via, we do a lot of assessing now, as we've had to do, I suppose, on screen. But I would certainly be very wary on the foot sharp debriding.
Wonderful. Thank you for answering that one, Jill. And at this point as well, everybody, I am going to welcome on my colleague, Vicky, who's in clinical support at BioMonde. Vicky will be here just to support Jill with the questions and to answer anything specifically around larval therapy. So let's have a look at the next question for you, Jill. This is from Louise, and she's asking, what would be the best or the safest offloading device option for a dementia patient who's at risk of falling?
I think if the patient's mobile, it's very difficult to do. I think probably the PODUS boot for me, you need something that's going to be flat, and it depends whereabouts the wound is as well, because the actual the peg assist, where you take the pegs out of the sole of a shoe, or where the patient can still remain in flat supportive footwear, is quite good. But also podiatrists can look at putting padding and deflection into a shoe, quite special and specialist for that patient. So it would be a careful assessment, but any device that takes the balance off that patient, as we discussed, it is really hard to do, especially if the patient's quite independent and up and walking around with dementia. So I'd go for something that was flat in shoe, really.
Brilliant. Thank you for that one. And the next question for you, Rob is asking, what is your perspective on managing patients with orphan heel syndrome, and when would you be prepared to debride these patients' wounds?
Well, that's a really interesting one. I don't think I've come across that before. Orphan, what was it? Sorry,
orphan heel syndrome.
Orphan heel syndrome. I would have to get back to him on that one. I can do my research, and certainly if he wants to email me over individually, I'll get back to him on that question.
Oh, lovely.
Yeah,
Thank you for that,
you.
Jill. So the next question for you, Louise is asking, what are the essential checks required before attempting debridement? She says she's seen a lot of double layer inidine being used on intact necrotic heels.
Yeah, inidine is a really, really contentious issue, and podiatrists are quite guilty of using inidine and overusing inidine. I think if something is intact, then you would only go for something maybe non-adherent like a trauma to go in contact with that dry area. Than the natural inidine we use quite prophylactically in podiatry to prevent any infection if there was some sort of peripheral breakdown of tissue. And the other part of the question on assessment for debridement, I think it's really important that you're completely competent, and there are sharp debridement courses available that are validated across the country, and podiatrists cover that as part of their degree training. So I think you'd need to be really careful before you did any sort of sharp debridement. Was the question around sharp debridement, Rebecca, or just debridement?
It was just debridement.
Well, that's a massive subject, and you would consider the whole wound bed, what the wound looked like, the patient's status, which we talked about in the presentation really, what their nutritional status was, what their healing was going to be like, the whole raft of things before you look at what debriding agents you would use. And there's a whole raft of debriding agents as well, depending on what the wound bed's like, whether it's moist, dry, wet, gangrenous. So it's another subject in itself, really.
Yeah, of course, completely understandable. Thank you, Jill. The next question from Rob, he's asking if we are able to successfully heal these complex heel wounds, often we lose a lot of the adipose tissue surrounding the heel. So what would you offer these patients to help with the reduction of pressure over these areas to prevent a recurrence and further breakdown?
Yeah, that is a difficult one, and you do think to yourself, we've got a fantastic result and we have got these heels intact. However, yeah, like you say, the fatty tissue is diminished. We've generally got scar tissue, or even part of the calcaneum is missing through osteomyelitis, for instance, or calcanectomy. And it's very difficult to get those patients back on their feet, if you like. I would make an appointment, a joint appointment with an orthotist, as well as thinking, if you're a podiatrist, what is available out there to you. Soft casting does have a place as well. That can help redistribute the pressure around the heel. But it depends on the severity of the scarring, what size the wound has been previously. But I think, yeah, again, we've got to think about mobility and balance, the patient's independence. I've got the patient I talked about that's got the bilateral tibial osteomyelitis in the heels. She's at a point now where her heels are intact, and I've got to think about how I'm going to start to give this lady her independence back at 46 years old. So my plan is to get a joint appointment with the orthotist and discuss the options there to him and see what he can suggest as well. Because as I've mentioned before, they're really inventive at coming up and messing around with adapting shoes and devices. So yeah, I think that building your multidisciplinary approach to it all, somebody may have some really good suggestions out there, but careful assessment.
Yeah, perfect. Thank you. And someone is asking, I think this is in relation to one of the case studies that you went through. What range is an OK HbA1c?
Well, all diabetics are generally present in their 40s, 60s, really. So you've got to make sure that your HbA1c is well controlled to a limit that can be managed without developing the long-term problems like retinopathy, neuropathy. And patients that come in their 80s and 90s, 70s, 80s, 90s, really, and into the hundreds even, that's when alarm bells really start to ring, and they will generally have already got some of the complications that go with the long-term poor control. The diabetic specialist nurses are fantastic, and the diabetologists, about all the new medications and what's out there for that control, and it's fascinating. It fascinates me every clinic what they say, and I learn from them. They're brilliant.
Fab, thank you. The next question for you from Penny. She's asking, what is DATIX or DATIX reporting?
All right, so Penny, that's something that's national. It's a national thing, and it's what we call a data report. Is something when you get an incident or something that's adverse in your practice that you notice, or say I went along to a patient and they've got a deep tissue injury and they lived in a nursing home, and I was the first person to be presented with this. I would put a DATIX report in, and it's basically electronic form which you have different options to scroll down, and you explain what you found, where you found it, and when, and which disciplines were involved in that patient's care at the time, and also then it is investigated. It's part of the trust responsibility to investigate that report, to look at, like I said before, not particularly who's to blame and who we can beat up about it, but what we can learn from those experiences. And also the DATIX reporting team, they're a completely different IT team. They will look at themes that are coming through. So are the different, are we getting quite a lot of those sort of heals that are coming through as a certain area of work, and do we need to put in training and practical sessions into that area of work to prevent that from happening again?
Lovely, okay, thank you. And the next question we've got, someone is asking, do you have any recommendations for those podiatry patients with pressure ulcers that are not diabetic? How do you refer them on or even get offloading boots for them?
Well, it's a bone of contention for me, and I actually feel that we should be treating non-diabetics as well as diabetics. However, I do appreciate that in some trusts, non-diabetics are not seen in the MDT for clinics. We're very fortunate about building relationships with our vascular teams that we do fit patients in that are not diabetic into these clinics, etc. So I would treat a non-diabetic wound and offload pressure on a non-diabetic patient as I would a diabetic patient. But I think it's about fighting the powers that be in making sure that is built in as part of your service spec, really.
Yeah. Oh, fab. Thank you, Jill. And the next question we've got for you is, what is the best offloading device for an obese single limb patient with a large heel ulcer and they're concerned about balance?
So I would go for, probably, without seeing these patients and individually assessing them, I would look at probably a heel wedge shoe, depending on what their mobility is like and how much they mobilise, whether they could be given a walking aid, whether it be a Zimmer frame, a wheeled Zimmer, a tri frame, or just a walking stick. What we don't want these patients to do is furniture walk. But it might be you need to, which I have done before, is work in conjunction with your physiotherapist. So looking at, and occupational therapy, so looking at aids to daily living, where the patients can have adaptations or be given devices to help them with their balance. I think it's getting to get that weight completely off. A PODUS boot may get that weight off, but I think it's probably going to be about a heel wedge shoe, really.
Lovely. Okay, thank you very much for answering that one. The next question we've got for you, and these are keeping coming in, so thank you very much, Jill, for answering them all very well in lots of detail for everybody. That's great. So the next question is, how long do you find the peg insoles last in an average weight individual?
Quite a while, actually, because when you take the pegs out of the insole, you also then put a lining on top. So it stops that collapse of the cavity that you've made to relieve the pressure off of the wound or the area of build-up. And so on average, well, they can go quite a few months with them in shoe, and it's about every time you see that patient reassessing, as we said before, taking their socks and shoes off, but looking at the quality of that insole. Is it bottoming? Is it time that you reordered another one? And when you're up against ordering these things and what people say the cost of these things, you've got to remember that the ultimate aim is to get these wounds healed and to keep these patients mobile and independent. So the cost of of whatever device you fit onto a patient, to me, is peanuts and pennies for what you're providing that patient ultimately.
Yeah, of course. Oh, brilliant. And the next question we've got for you from Gladys. She's asking, how do you feel about the removal of offloading devices like air cast boots? Are they preferred generally than TCC due to cost? Yet you mentioned that TCC, apologies, is the gold standard.
Yeah, I mean, ICAS walkers are brilliant. They really do have a place, however removable. So it is around looking at that again, assessing that patient as an individual, and realising whether they are not trusted, but whether they are going to do exactly as you ask them to do. So just removing that device on a night when they go to bed, so that they I mean, some patients will even sleep in them. They're that strict on wanting to get things right. So if you've got a patient like we've had, just as an example, I'll try and think of things and it puts it into perspective for you, is that we've got a patient at the moment where I work who has been, we know because we've seen him around and about, it's a small world that we live in, he's been seen not wearing his air cast walker and he's got a Charcot foot, for instance. So we've had discussions with him and he's quite happy to go into a total contact cast, and that is non-removable. However, it does put strain on the plaster technicians in the plastering, in that particularly if they've got a wound, we have to go weekly to remove that cast, assess and redress the wound, do whatever we need to do to the wound, and then he has to be recast again. But he's finally taken that on board. He was a builder, he had to drive, he had to work to pay bills, but he's finally decided that this is actually quite crucial. So we've had good results with both. It's about, like I said in one of the slides, it's about knowing your patient.
Yeah, of course. Oh, brilliant. So the next question for you from Vanessa is, what temporary measures would you suggest until the patient can get to the right address? Until now, she said she's been having patients sit with their foot half on a thick sponge to avoid heel pressure. But obviously, she said that's just something very basic for them for the time being.
Yeah, I mean, anything that's where the foot is elevated and on zero pressure, like I mentioned before, that the pillows do work, they do have a place, but the quality of pillows across the hospital sites particularly is quite reduced, and I have been known to double a pillow over and that's gone so thin and pop the foot under that, but make sure you support that calf muscle as well, so that we don't get pressure damage of the calf, which has been known. But elevate onto a buffet or a footstool if they're at home, or if they've got recliner chairs, like I say. It's really good to just know that that foot is positioned so the heel is literally floating in midair.
Great, thank you, Jill. And the next question we've got is someone's asking, how do you make a cast? And is there any training required for that?
Absolutely, yeah. Yeah, very much there is training for that, yeah, and it takes quite a while to be competent at doing that and confident at doing it as well, because you need to be very organised in how you put that cast on. You've got to know the pressure areas, where you're going to reinforce that cast, because it's reinforced over the sites that have got tissue breakdown or pressure that need preventing. So you have to have the right kit and the casting, and so there are training. There is training available by the soft cast manufacturer, but what we do as a podiatry team, we'll cast each other. So we'll have meetings, do practical sessions where we train podiatrists, and we'll go out with patients and see them when they're needing a soft cast, watch them go through that and then sign off the competencies. So it's not just about us popping a cast, wrapping the foot in bandage and it being a cast. It's got quite a lot of complications as well. And if you get really good at it, you can get 2 heels out of 1 cast roll, but that takes a lot of experience.
Oh, brilliant. Thank you, Jill. And thank you. You're answering these questions beautifully. So I'm sure everybody at home is very grateful. And thank you to everybody for continuing to, get your questions into us. And don't forget, we've got, obviously Jill is here with us this evening, but we've also got my colleague Vicky, who can answer any questions around larval therapy for you as well. So do feel free to ask away and just type those questions into the Q&A section on Zoom. So the next question we've got for you, Jill, from Rob again. He's asking, now with the likes of the Motor Smart Boot, we can ensure compliance in wearing removable devices. And he said we can always render them TCC with some taping around it. So what's your opinion on that?
Yeah, I think the more offloading devices we have available to us, I think, as podiatrists, we've got to evaluate the patient, assess the patient, and know the more that things will develop. I'm sure in the years to come, there'll be more and more offloading devices out there. There's a whole massive business of offloading, and it's up to us as podiatrists to try out those, try out those devices, see what's right for those individual patients. And yeah, if you feel that offloading device has a place, then certainly, use it on different patients. And I've built like a little, I suppose, like a little bit of a portfolio over the years in my head, that when I'm assessing that patient, I try and think in my head while I'm seeing them, right, they'd be good for that, and they'd be good for that. I could try that, but I won't use that. And that's a sort, like you're assessing a wound bed and you're thinking what debriding agent to put on. It's the same thing. You're moving on from, right, the heel needs debriding agent, it needs offloading. What am I going to do about that? How am I going to involve this discipline, that discipline? And all this goes on in your head. But any offloading devices, and share your knowledge. If anything's really good, share that knowledge. Let's hear about it. Yeah, fantastic.
Oh, wonderful. Thank you. Another question for you then. So someone's asking, how would you approach blisters on a dorsal foot in a diabetic patient?
Number one, do not lance the blister, whatever you do. Do not, like we would expect and hope that blister would reabsorb. Please, please don't ever lance a blister on really any foot, but especially a diabetic foot. So depending on what was the causative factor of that blister, again, sometimes the patients come to you and they say, oh, I don't know where it came from. It might be a burn, it could be a trauma, it could be trauma from too tight footwear, it could be a hot water bottle, it could be that they've had their feet up against a radiator, it could be that they've dropped something on the foot and it's blistered. But always look underneath, see if there's any bruising, if there's any change in that skin and tissue viability, because the blister could be something that's at the surface of something that's going on very, very wrongly underneath. So photographs, I always try and photograph nearly every wound I can do, really, not only for my benefit, but any of the colleagues that are going to follow on to me of other disciplines that can then look at that and think, oh, has that deteriorated, has it improved, etc. And obviously gaining consent from that patient as you're doing it.
Fantastic. Thank you, Jill. I think that's it with the questions for now, but we've had a lovely compliment come through for you, Jill, from Catherine. She's asking, please, can I book Jill for Dishforth Village Hall events? She would be perfect.
Yes, you can. Yes,
oh.
you can. As long as it comes with cream cakes and chocolates.
And just to finish then, I can see, Vicky, we've actually got a question that's just popped through for you. Alana's asking, they're on the Isle of Man. Unfortunately, they've struggled with the transportation of larvae in the past, and they've also had some issues with non-viability as well. But they're asking, are there any new improved methods as they feel as though they're missing out on this method of debridement?
Well, I mean, we are certainly always looking at our careers, and Rebecca will agree with me. This is something we are constantly reviewing, and we are actually trialing some different ones at the moment. So, if you've got a patient who you think is suitable, then you don't hold back from asking. We'll figure out how to get it there for you. And we're really supportive if you are having problems with larvae not being viable when they get to you, then we will figure out a way to get them to you. So,
yes,
you know, we're very, very determined, aren't we, Beck? So,
yes,
you know.
definitely. And we will be popping contact details on the screen for you very shortly. So do feel free to give us a call anytime if you've got any questions around larval therapy, and, you know, anything, we can always answer those for you. Yeah. So the next question we've got from Sharon for you, Vicky, is there a recommended wound debridement course? And feel free to answer that as well, Jill. That may be applicable to you also.
I'm not sure if there's specifically a debridement course that I would recommend. I'm tissue viability by trade, and there's certainly some really good tissue viability courses in the country that would cover wound debridement. Obviously, you've got your sharp debridement courses, and I know there's a couple across the country, but not sort of not I know of anyway, not a one just on wound debridement.
No, and I agree, Vicky. I think, you know, it's all part of wound management, and it's encompassed in part of wound management. And wound debridement is just a small tip of the iceberg of how we manage wounds, particularly on the foot.
Brilliant, thank you.
Sharp debridement, she said. I could see that now, Shabby. Yeah. Yeah, like Vicky said, there are some actual certified courses that are run across the country, and there are 2 that I know that run. I think it's probably worth contacting possibly the Tissue Viability Society. If you email them, they put that out on a group chat, and then they'll tell you what's available on the group chat around the country. So being a trustee, I do know that patients and public can email into the Tissue Viability Society. So that's probably your best starting point there.
Oh, fab. Thank you for answering that. And we've had another question come through from Jane. She's asking, what is the best way to avoid the larvae getting squashed when used on the heel? So Vicky or Jill, feel free to answer.
I mean, there's a couple of different ways, and Jill, you might have your favourite ways. It massively depends on the situation with the patient, though, to be fair. I mean, it might be that you have to go for the, you know, the extreme of offloading in bed for the few days that the larvae are in place. You might be able to, I know some podiatrists will build up around the wound with I think it's the foam that you use to sort of build up an area so you don't squash. Heels are really, really tricky. They don't like being stood on or sat on, generally, maggots, so it is tricky. Sometimes I've had younger patients who have had the Darko shoes, where you're weight bearing on the front of the foot instead of the back. Like I say, for me, it massively depends on the situation with the patient.
Yeah, and we I think offloading is really, really difficult, as you probably proved with the presentation I've just done. And we can use it's a semi-compressed felt that we use, and that's supposed to redistribute the weight around a specific area of the foot. However, if you've got a wound and then a dressing, and you've then got to remove that to dampen the larva therapy, it's hard to keep that going if you're doing it in conjunction with district nursing teams as well. So you'd probably look in podiatry at more of an offloading device than felting it round and relieving the pressure that way. But I have done like Vicky said, and advised the patient to just be in bed for a few days, to be honest.
Yeah.
It never goes down very well, but
it's a bit short-term pain, long-term gain, though, isn't it?
Yeah.
Oh, thank you both for answering that one. As far as I can see, that is it for the questions. So thank you very much, ladies, and thank you to everybody at home as well for submitting your questions to us. And of course, if you do have any burning questions, do feel free to still pop them in. We can squeeze them in at the very end for you as we say goodbye. And just to address, I can see we've got some questions popping through just about slides and certificates. So we will be sending you emails with information just following the webinar. So just so you know, for any upcoming dates, we are actually having a break for the summer. So this is the last BioMonde live webinar until September. So thank you everybody for joining. It's been really, really great to have you here this evening, and we really hope you've enjoyed. But if you would like any further information about BioMonde Live and what we do, myself and my colleague Vicky, who you can see on screen, we host live level webinars every Thursday evening. And do feel free, like you've done with this webinar, to log on to our website and register for any of those. And as we've mentioned, we are of course always here for you to contact if you have any questions at all. We've got our dedicated clinical helpline, which you can call anytime. We've also got our newly launched website, biomonde.com, which you can visit, and there's loads of great new features on there as well. And then of course you can always email us, clinicalsupport@biomonde.com. And don't forget as well, we are on social media. So if you love social media as much as we do here, then do feel free to give us a follow, give us a like, and leave a comment as well. But thank you everybody once again for joining us. We really hope you've enjoyed BioMonde Live, and thank you so much, Jill, for your amazing presentation. I loved it, and I'm sure everybody at home did as well. And thank you, Vicky, for joining us for the questions. But we will let you all enjoy the rest of your evening, and thank you once again everybody for joining us on BioMonde Live.